inviting me to be with you today. I have the following conflicts of interest. I am lead author or co-author on 8 up-to-date cards for hyperparathyroidism, and I served as a co-chair for one of the 4 task forces for the 5th international workshops. These are the 4 task forces, but I'll summarize the work done by all 4 of us that's published in JBMR. The learning objectives are to appreciate the spectrum for the clinical presentation of primary hyperparathyroidism, implement the appropriate workup, select care pathways based on evidence for medical versus surgical management, and apply an appropriate monitoring strategy. So how are we going to do that? I'm going to start with a definition, go on to physiology, pathophysiology, genetics, epidemiology, and clinical presentation, moving on to diagnosis, differential diagnosis and evaluation, and the meat would be the guidelines for management, practical considerations and pitfalls, and a summary. So what is primary hyperparathyroidism? It is an autonomous, non-suppressible PTH hypersecretion that is inappropriate for the degree of hypercalcemia, emanating from frequently one or more than one of the 4 parathyroid glands. Hypercalcemia with high PTH is present in the majority of cases, but hypercalcemia can exist with inappropriately normal PTH levels in 15%. This is a graph, actually, that is generated from work I did at Brigham's many years ago. On the y-axis is PTH in picogram per ml. On the axis is total calcium. The green inverse sigmoidal relationship is something we characterize in normal healthy volunteers. And what you see here in triangles are hyperparathyroidism, so high calcium and high PTH. Here are hypercalcemia of malignancy, and these are hypopara. And as you can see, the majority of patients with hyperpara have a high calcium and a high PTH, but you have 15% who have a high calcium, but an inappropriately normal PTH that's in the upper limit of normal. And we call this a shift in the set point. The set point is the point at which, here it is, there is 50% suppression in the sigmoidal curve. And as you can see, this is a normal curve. This is primary hyperparathyroidism. FHH is another entity that shifts the set point to the right. And of course, ADH and hypopara are shifted to the left. Well, how do we get there? First of all, let's review quickly the physiology of calcium and phosphate metabolism that is mostly regulated by the master hormone parathyroid. When there is a slight drop in serum ionized calcium, PTH levels will go up from all 4 glands, stimulating bone resorption to mobilize calcium from bone, stimulation calcium reabsorption in the kidney, again mobilizing calcium into the circulation, and if chronic, activating calcitriol secretion from the kidney, which enhances intestinal calcium absorption, all of which will normalize calcium and phosphate. But because PTH is phosphaturic, the phosphate is excreted, and you therefore correct the calcium. What happens with hyperparathyroidism? Usually one of the 4 glands becomes autonomous. So it secretes a lot of PTH, and with that comes high calcitriol in 50%. So the pathophysiology is hyperabsorption at the level of the bone and the kidney, and bone resorption, hyperabsorption at the level of the kidney and the intestine, and bone resorption at the level of bone. So it's a double mechanism. Now, what is the spectrum of disorders that lead to primary hyperparathyroidism? The majority are parathyroid tumor. They could be sporadic, majority, either adenoma, 1% carcinoma, rarely parathyroidosis. Autoimmune hypercalcemia has been described in Edith Brown lab. Only 10 to 15 are inherited, and you can have 2 major categories, the syndromic with a known MEN1, MEN2, but we also have MEN4, 5, hyperparathyroid tumor syndrome, and the non-syndromic are the FHH subtypes with mutation in the extracellular domain of the calcium sensing receptor or anywhere distal to that. So these are the genes implicated. This is a very nice review by Will Simmons. I encourage you to pull that. But basically for adenoma, these are some of the genes implicated. For carcinoma, it's CD73, and so on and so forth. We won't get into that. Well, what has happened over the last 50 to 70 years? Hyperparathyroidism today in many countries, including some of the Gulf countries, can still be asymptomatic. It predominantly affects postmenopausal women because of the unmasking effect of PTH bone resorptive on bone after estrogen is decreased from menopause. It could be symptomatic in countries with severe vitamin D deficiency, but it could be asymptomatic in countries where automated chemistries are done. Of course, we've seen the syndromic and the non-syndromic, and I'll discuss in a minute the classic versus a non-classic manifestation of hyperpara. Risk factors, we always inquire about lithium intake, thiazide intake, which may bring out hyperparathyroidism, radiation to the neck for acne as children, etc., and of course, family history, and looking at all labs. This is a nice review done recently after the Hyperpara workshop at a color-coded map where the prevalence of symptomatic disease is less than 25% in Europe. So North America, South America is usually asymptomatic. In brown, the majority are symptomatic. This is some parts of Southern America, South Africa, but also some parts of the Middle East. We don't have Lebanon. Saudi is symptomatic according to this map. Russia is in between 50 to 71%, and China is 25 to 50% symptomatic. The classic manifestations are bones, stones, and groans. This is the classic. Bones with fractures, stones with kidney stones, groans not feeling well, but it's shifting to asymptomatic disease in many countries, as we said, doing automated serum chemistries. What makes the disease symptomatic? In developing country, it's felt that the high prevalence of vitamin D deficiency is one of the main factors. And of course, the presentation depends on whether we do serum calcium level routinely, whether we're doing thyroid ultrasound routinely, what are the dietary habits of the population, what are the genetic polymorphism, and what do we know about the calcium sensing receptor. Although we said the Gulf area and the Middle East may be more likely to be symptomatic, I wanted to share with you the profile of 68 patients. This is a paper that's in submission, where we looked at actually different assays and whether we do central or peripheral intra-op PTH. But the gist of the paper here is to show you that the average age was 57, of course, as expected, 80% females, calcium not very high, 10.8, PTH 103, the interquartile range is anywhere from 82 to 152. 1/4 had osteoporosis by BMD. 1/4 had kidney stones. The pathology in 82% with a single adenoma, double adenoma in 10%, and more than 3 glands in 8%. This is actually from our review in the workshop where we're coding in red the classic manifestation. These are felt to be directly due to the PTH effect: hypercalcemia, hypercalciuria, hyperuricemia, hypophosphatemia, but importantly, the end organ of kidney and bone. And in the kidney, the manifestation may be polyuria because of the effect of calcium on the aquaporin molecules in the kidney, nephrolithiasis, nephrocalcinosis, impaired renal function, and at the skeleton, bony pain, osteoporosis with fracture. Osteoarthritis fibrosa cystica, which I'll show you in brown tumor, is very, very rare, less than 1% nowadays. Probably still seen in countries where vitamin D deficiency exists. So red is directly related. Green are the non-classic associations. You know, cardiovascular association, hypertension, arrhythmia, calcification of the valves, hypertrophy, GI manifestations, neuromuscular manifestation are indirect, non-classic, and we cannot say that there is a cause effect between PTH and those. So clearly in developing country, hyperparathyroidism has been slowly evolving as asymptomatic disease. The prevalence of kidney stones was almost 60% in the 30s to the 60s, all the way down to 14 to 20% more recently. Hypercalciuria is still common, and if we check those patients, we do find high urinary calcium. Overt skeletal disease is very, very rare. We pick it up as asymptomatic by bone density. The urine profile is high phosphate because PTH is phosphaturic, and because they have distal RTA, they have an alkaline urine, and the tip-off is a mixed calcium phosphate, calcium oxalate stones. So what are the skeletal findings? Because of the PTH effect on bone resorption and bone turnover, there is slow bone loss, mostly at cortical sites. So they have low BMD, more at the forearm than the hip and the spine. They have fracture at all sites, and very rarely in severe cases, they have the brown tumor, osteoarthritis fibrosa cystica. Modern hyperparathyroidism picks mild cases most of the time, Rarely do we see osteoarthritis fibrosa, at least in Lebanon. This is the typical BMD profile from the Columbia series. The spine is the best. The femoral neck is in between. The 1/3 distal radius, which is 80% cortical bone, the lowest. And what we see here is fracture risk in hyperparathyroidism from a constellation of studies, vertebral, distal forearm, rib, and all. And whichever way you look, the observed rate of fracture exceeds the expected by at least 1.5 to 2-fold, whatever you look at. Importantly, these vertebral fracture, this is fracture cases. This is a study by Vignali and Claudio Marcocci, whether they're symptomatic or even asymptomatic, the prevalence of vertebral fracture is high, although it's higher in those who are symptomatic. And I think it's a very important point and take-home message. Clinically asymptomatic does not mean that they are free of end organ damage. These are a few x-rays. This is a classic osteoarthritis fibrosa cystica. We rarely see this, if any. By the way, this is another beautiful review by Rumpu in Endocrine Reviews 2025. What we see here is, again, osteoarthritis fibrosa cystica along the left leg. And this actually HRPQCT image of the 1/3 distal radius in a normal person with thick cortices and connected trabeculae, and in a person with hyperpara where the cortices are thinned out, and you can see there is a lot of disrupted trabeculae. Now, what are the other manifestations for the syndromic? Of course, I won't be able to review this, but this is from Bill Simmons' review again. MEN1, the penetration of hyperpara is 100%. MEN2, it's only 30%. But there are parathyroid tumor in MEN4, which is accompanied by net tumor, as is MEN1. And also you can actually see parathyroid adenoma in MEN5, which is dominated by adrenal problems. And in the hyperpara jaw tumor syndrome, which is familial, and 20% increased risk of parathyroid cancer in those with a high penetrance after age 50. So you can have other end organ manifestations if it's part of an MEN, but this is rare, and I think I've seen maybe a handful over my career. Now, how do we diagnose hyperparathyroidism? The first thing I ask my residents when they say we have a hypercalcemic case, I say, what's the PTH and what's the vitamin D? So let's go through this. In the workshop, we have actually defined hyperparathyroidism as either hypercalcemic or, as I'll show you in the next slide, normal calcemic. Hypercalcemic hyperpara is defined by an elevated serum corrected calcium for albumin in the presence of an elevated, in 85% of cases, or inappropriately normal PTH, regardless whether you use second or third generation, on 2 occasions at least 2 weeks apart. One value with 1 PTH is not enough. What is the differential diagnosis of hypercalcemia and high PTH level? Well, right after that is another benign inherited condition, autosomal dominant FHH. You should suspect that in younger individual, when the calcium over creatine clearance ratio, as I'll show you, is low, and certainly when there is a family history because it's autosomal dominant. You can also see patients who are hypercalcemic on thyroid, diuretics, and lithium. And if they've been on it for chronic enough time, they may actually have hyperplasias or adenomas in their parathyroid. And of course, very rarely some tumors secrete PTH. These are extremely, extremely rare, but that could be possible. Now, what about normal calcemic hyperpara? This is one that's more tricky. It is characterized by a normal adjusted total calcium and normal ionized calcium, along with elevated PTH using second or third generation, on 2 occasions again, but 3 to 6 months apart, after all alternative causes for secondary hyperpara have been ruled out. And what are these causes? Well, CKD, GFR less than 60, idiopathic hypercalciuria or loop diuretics, calcium malabsorption, whatever the cause is, and medications that are potent anti-resorptive. And of course, we talked about the lithium bringing out hyperparathyroidism. Now, this is a slide I show over and over again in textbook and chapters. It really captures the biochemical abnormality in hyperpara, which is more common than FHH, but yet they could look similar. In both entities, especially in developing countries, the serum calcium is mildly elevated. But because the FHH is characterized by mutation in the sensing receptor. And because the receptor senses calcium, but also magnesium, at the parathyroid gland and at the kidney, there are some differences. The serum magnesium in hyperpara is normal to low. It tends to be high in FHH. It parallels the calcium. Phosphorus, most of the time in our patients, is normal, but it could be decreased in hyperpara. It's normal in FHH just because the PTH elevation is less. PTH is elevated in the majority of hyperpara. It's normal in 85%. Urine calcium over 24 hours is elevated in hyperpara, usually less than 100 milligrams in FHH. Calcium over creatine clearance ratio has been the ratio that people talk about. It's less than 0.01 in FHH. In most cases, it's more than 0.02 in hyperpara in the majority, over 50% of cases. So how do you differentiate them if you're in the clinic? First of all, always inquire about family history, retrieve all values. I tell my patient, bring me values from 5 or 10 years ago. FHH is born. People are born with it. Should have been there all the time. Now, if both entities are characterized by high calcium and normal or raised PTH, I do a 24-hour urine collection, and the calcium over creatine clearance ratio, if below 0.01, makes it likely to be FHH, but not diagnostic. It's a condition that's autosomal dominant. But remember, you could do gene testing, and in 20 to 25%, you don't have a mutation detected. You do not want the surgeon coming close to these patients. If the calcium over creatine clearance ratio is more than 0.02, it's likely hyperpara, familial or sporadic, more common sporadic. If it's familial, these are the entities and the genes involved. But often you'll find it in between, in the gray zone, and I made it gray here. So you're unable to distinguish. And always go back to old labs, family history, sit on the patient, no rush to take them to surgery, and help yourself with genetic testing. So I'm going to be summarizing now the recommendations. There are 12 of them. The pregnancy I won't cover. 11 I'll cover here. We already talked about the diagnostic recommendation. Now, what are the phenotype? Well, we said there's the symptomatic in developing country, in countries with vitamin D deficiency. There is the asymptomatic in developed country, discovered on screening. And there are two forms of asymptomatic. And this is a new thing we did in 2022. A patient may come asymptomatic and you say, do you have stones? No. Do you have fractures? No. But they may turn out to have stones and nephrocalcinosis if you test them. And they may have turn to have osteoporosis or asymptomatic vertebral fracture if you test them. So now we've separated the asymptomatic into two forms. Asymptomatic with target involvement detected upon testing, and I'll show you what that is, or without target involvement. And then there is the normal calcimic, which is normal calcium, high PTH, and they certainly can have skeletal renal complication, or they may not be present. So how should we evaluate patients? Well, since I've already told you there are end organ damage, you need to look at those. You need to do your biochemistry, measure total serum calcium, ionized if the patient is normal calcimic more than once, phosphate, PTH, vitamin D, creatine. Doing a bone densitometry alone is not enough. You should do imaging for asymptomatic vertebral fractures, either by X-ray or VFA, and if possible, do a TBS, trabecular bone score, which is trabeculation quality of bone, which is low in hyperpara. You want to do a serum creatinine, ideally an estimated GFR, 24-hour urine calcium, creatinine, and you may want to do a risk profile for stones and imaging, of course, for nephrolithiasis and nephrocalcinosis. Non-classic manifestation, neurocognitive, quality of life, cardiovascular, no data to support routine evaluation, and certainly no data to support surgery for these indications. And genetics should be considered in young patients, those who are known to have multi-gland disease in the family, and those with a family history of hypercalcemia or any of the syndromic forms that I shared with you. Now, what about other guidelines for management? What are the indications for surgical management of asymptomatic hyperpara. We did systematic reviews. Some of these recommendations are graded because there was enough evidence, and some of these are ungraded, and we separate them here. So in the hands of experienced surgeon, surgery should be used to achieve biochemical cure if there is no contraindication. High quality evidence, it's a graded statement. Surgery is curative in patients with established hyperpara. The ungraded panel is surgery is recommended if the patient meets any one of the guidelines for surgery that I'll share in a minute and have no contraindications to surgical intervention. Surgery cannot be recommended to improve neurocognition, quality of life, cardiovascular manifestations. So what are the indications we set for the ungraded recommendation? Well, a calcium more than 1 milligram or 0.25 millimoles above the upper limit. Involvement of the skeleton, either a BMDT score less or equal to minus 2.5 at any site, or a fracture by VFA or X-ray. Renal involvement, creatinine clearance less than 60 with no other reason, nephrocalcinosis or nephrolithiasis, hypercalciuria. Please see the difference in the levels for 24 hours. In women, 250, in men, 300. Some people use 4 milligrams per kilo. Age less than 50, because if they live long enough, they may carry complications of hyperpara. You want to prevent that. And even if none of those are fulfilled, parathyroidectomy is still an option with concurrence of the patient and physician, because that is the curative surgery that will give you benefits. And I'll show you that in a minute. And the benefits are increase in bone density. This is 1, 5, 10, 15 years. Most of the gains are early on at the lumbar spine, at the femoral neck, at the distal radius. And there is data that hypercalciuria improves. We don't have very convincing, but some data exists on improvement in kidney stones. We don't have decrease in fractures after parathyroidectomy. What is the role of pre-op imaging and intra-op PTH measurement? Pre-op imaging is not recommended for diagnostic purposes. You can have a false positive and a false negative. Pre-op imaging is recommended for those who are going to have parathyroid surgery in order to locate the abnormal gland. The imaging modality, depending on your center, could include high-resolution ultrasound, system IBI scan, or contrast-enhanced 4D SPECT. PET choline is still felt to be a research tool, although it's used in Europe. With successful pre-op imaging, selective parathyroidectomy combined or not with intra-op PTH monitoring achieves high cure rates in the hand of experienced surgeon, as noted in the previous recommendation. Advantages of minimally invasive parathyroidectomy is shorter operative time, less scarring, less risk to surrounding structure, hypoparathyroidism, and potentially reduced cost. There are no really good head-to-head comparison. Right now, we have actually a Cochrane review on the topic a few years back that you're welcome to look at. Parathyroid surgery, importantly, should be performed by experienced endocrine parathyroid surgeon. Now, why is parathyroid imaging challenging? Well, this is because the parathyroid are small. They are the small pea size. Variable location due to the embryological development. Variable imaging characteristic. You can have double adenoma, one shows, the other doesn't. It's asymmetric. Some enhance, others don't. Some take up system EB, others don't. And the average weight of parathyroid gland is very small. So the accuracy of the imaging modality, this is an up-to-date card with sensitivity, positive predictive value, can be quite high. 4D CT seems to be pretty good and actually even better than system EB SPECT, but it depends on the experience of your radiologist. What is the role of non-surgical medical management? Those who are not eligible or refuse surgery. These are ungraded recommendations because there is limited data and quality data from an randomized trial. Let's start with a drug. Alendronate and denosumab have been used and shown to increase bone density. Cinacalcet can be used to reduce calcium into the normal range, slight decrement in PTH, no changes in BMD. All patients with hyperpara should be on enough calcium supplementation, ideally from diet, less than 50 women and less than 70 men at 800, and a gram for women and men who are older. And you need to hope to achieve vitamin D levels above 30, but stay below 50 to avoid intoxication. Estrogen has been shown to increase BMD, Raloxifene has been shown to affect markers, and there is no BMD data. And this table really summarizes it. The only drugs that increase bone density are HRT in younger women, alendronate and denosumab. Cinacalcet, no change in BMD, but decreases serum calcium. For the rest, everything is just about stable. How should we manage normocalcemic hyperpara? Well, this is one of the recommendations that changed compared to the prior workshop. Because of the limited data, we cannot recommend guidelines for surgery in normocalcemic patients at this time. We used to recommend surgery before, but now we're more iffy. If there is evidence of end organ damage, you could discuss it with the patient and go for it, especially if they're young. What about monitoring plan in patients who do not have parathyroidectomy? Well, every year we need to do some biochemistries, calcium, creatinine, vitamin D, PTH if clinically indicated, skeletal films for DEXA every 1 to 2 years, for vertebral X-ray. If indicated, I always measure the height of my patients when they come to clinic, and if they don't have scoliosis, I rely on serial height measurement to decide on X-ray. Renal parameter, creatine clearance, abdominal imaging if clinically indicated, and a 24-hour urine calcium if clinically indicated. When should you recommend surgery in a patient who was monitored prior? It's very similar to the indication for surgery to start with. Serum calcium above 1 milligram above the upper limit, low trauma fracture, kidney stone, significant reduction in BMD, significant reduction in creatine clearance over time. This is actually a study that the Bilzikian group in Colombia published, and you can see the first 10 years, bone density seems to be pretty stable, but you go on, and then with time, you start seeing cortical bone loss at the femoral neck and the radius. There was a high dropout rate. The number of patients followed was much smaller. I actually wrote an editorial way back then, this is almost 20 years ago, and said, why not do surgery on everybody if they do not have a contraindication and if you have a good parathyroid surgeon? So in patients who meet surgical guidelines but do not have surgery, what are the approaches reasonable? Again, the ones we use in medical therapy: calcium, consistent with nutrition guidelines, vitamin D, not to be deficient. If need be, we can decrease calcium with Cinacalcet. And if they have severe osteoporosis, we can increase their BMD with bisphosphonate or denosumab. And if they have both a high calcium and a low BMD, you could use them in combination, but the data is fairly limited. So closing up with practical consideration, really normocalcemic hyperpara remains a diagnostic challenge. Remember the categories to be ruled out. Vitamin D deficiency can mask hyperpara, and once you replete them, you can see the hypercalcemia becoming more evident. Differentiations from FHH sometimes can be difficult. I've shown you the overlap in the clearance ratio. The age is different. FHH is young. Hyperpara is older postmenopausal. FHH has a family history. Hyperpara doesn't. But sometimes you don't have all the data you need. If you're not sure, sit on them, no rush to do surgery. Hyperpara is not a rapidly progressive disease. Imaging can be discordant. Sometimes surgeons do too, to guide their surgery and are a bit lost. That happens. And persistent or recurrent disease post-surgery is common in hyperplasia, but also if you don't have an experienced surgeon. So to close up, hyperpara is often asymptomatic in communities where biochemical screen is available. We still see symptomatic disease in the Middle East, that's for sure, because we still have some variable prevalences of hypovitaminosis D. The diagnosis is biochemical nowadays. Imaging does not confirm or disconfirm the diagnosis. Never rely on imaging. If you're not sure what the patient has, don't go to imaging. It will make it more confusing. Imaging has false positive and false negative. Surgery is curative. Medications only prevent end organ damage. Asymptomatic disease may turn out to have end organ involvement, and it's best to test, screen, and treat surgically. Normocalcemic hyperpara best management strategy is not clear today. Guidelines help identify who benefits most. Always rule out FHH before surgery. Family history, review old values. We have outlined many knowledge gaps in a research agenda in the JBMR supplement, which is shown here. And I'd like to thank you for your attention and for allowing me to be with you today.